ahead and get started so we start on time. So today, Grand Rounds, our speaker is Laura Loertscher from Providence St. Vincent. Many of you probably know her. She's been here since 2009. So she's originally from the Midwest, born and raised in Madison, Wisconsin. So I assume there's a cheesehead hat somewhere hidden in the back of her closet. She did her medical school at Mayo, also got a master's in public health at the University of Minnesota during that period of time. Then went to the Mayo for residency and served as a chief resident prior to coming out here to Providence St. Vincent's. Currently, she's an instructor in the internal medicine residency program over there, very active in the resident education program, is also their medical director of CME, kind of our equivalent of Liz here, and does these introductions. She also is a proud member of the women's futsal team, Providence, here with Mari Kai and company, and she has done Boston and Chicago marathons. So for a non-runner, that's impressive. So we're happy to welcome her here. She's going to talk to us a bit about uncertainty in medicine. So, welcome.
All right. Well, good morning, everybody, and thanks so much for having me over here on the east side today. I think, can you hear me all right? Yeah, great. So nothing like coming and standing up in front of an audience to talk about uncertainty, so we'll see how this goes. Looking forward to talking with all of you today. So nothing to disclose. And John already made reference to the fact that I have some deep Midwest roots. This is my Grandpa Walter. Many people called him Joe. And Grandpa Walter had a saying that went something like this: before something happens, it's too soon to worry about it. And after it happens, it's too late. So, as it turns out, it actually requires really meticulous predictions and planning to find success as a Midwest dairy farmer. But that said, there's also a tremendous amount of inherent uncertainty, a lot of things that are out of your control. And we as providers, as doctors, physicians, are often responsible for worrying about things before they happen, and sometimes even more so after they do. But that said, I do find a certain amount of wisdom in my Midwest predecessors, and as I think about how I sit with uncertainty and move forward in its face, in a field that has almost as much uncertainty as farming. So let's take a look at our agenda for today. Here are our brief objectives. We're going to define a little bit of what I mean about uncertainty in the context of medical care. We're going to understand some ways in which uncertainty affects us as healthcare providers. And then we're going to discuss some strategies for managing uncertainty. To some degree, this will be efforts to reduce it. And maybe even more importantly, we'll look at some ways to function in the face of it. So let's start off with a brief case. Here we are at Grand Rounds. You are seeing an 82-year-old man in follow-up for a lumbar compression fracture diagnosed by X-ray after presenting with low back pain. Because his pain failed to improve over 6 weeks and was bothering him at night, his PCP had obtained some additional workup. Labs results show he has baseline mild anemia and chronic kidney disease, and his SPEP demonstrates a mild, nonspecific elevation of alpha-1 globulin. All right, we don't have clickers today, but I'm going to give you guys just a few seconds to read our options here and commit in your own mind to what you think you want to pick. All right, let's go ahead and talk a little bit more. So here are his initial results. As you can see, this is pretty mild, but there's a little bit of bump in alpha-1 globulin on his electrophoresis. And if you order this test correctly, fortunately, it automatically reflexes to a serum immunofixation, as his did. And just as a reminder, the serum immunofixation, its purpose is to verify that a protein spike is indeed monoclonal, and also to help designate the immunoglobulin subclass, be it heavy or light chain, and the type. So as it turns out, his reflex was negative for monoclonal immunoglobulin. And just to remind us a little bit further, the Greek letters, the alpha, beta, gamma, don't have anything to do with the immunoglobulin subclass, but simply represent the movement of the protein through the agarose gel. And nearly always, all of our monoclonal antibodies tend to be in that gamma spike. Take a look here. So here, when we have a monoclonal gammopathy, and much less commonly in the alpha 2 range, but very rarely or pretty much not in the alpha 1, where our gentleman had his mild initial spike. So, as it turns out, fortunately, his test reflex to the serum immunofixation, which fortunately was normal, and perhaps even more fortunately, he did continue to feel better over the next few weeks and recovered. As a reminder, the serum free light chain ratio is something that you may get if your clinical suspicion for a monogammopathy remains high in the face of a normal SPEP, because your free light chains may not show up on the SPEP. So you might have noticed this isn't a talk about monoclonal proteins. This is a talk about uncertainty. This case is just to demonstrate that it turns out that a lot of what we do is pretty complex, pretty hard, especially when you don't encounter it all the time. But even for pretty basic labs and pretty basic chief complaints. So let's take a look at that a little bit more. Way back in 1957, Dr. Fox did some interesting work in defining uncertainty, particularly among medical trainees, among medical students. And she described 3 types of uncertainty. The first one was that arising from incomplete mastery of the vast and expanding range of medical knowledge and skills. Okay, so number 1, the person just doesn't really have the knowledge or skills yet, doesn't yet know what they're doing. There's number 2, which is uncertainty due to the limitations and ambiguities of that knowledge and those skills. So these are things that's uncertainty inherent to the evidence base that we have. Perhaps imprecisions in tests, for example. And then there's number 3, which is tricky, that you may not know which bucket you're in. So the uncertainties of distinguishing between the first 2. So as exemplified by the first case and a lot of other situations, I would argue that medicine is hard, and we're all forever students. And perhaps when we find ourselves in a situation where we are not positive if we're in bucket 1 or if when we're in bucket 2, these are the times we really need to maintain our curiosity, to go back to either the textbook or the article and read up. We may phone a friend, or we may get a consult if we need to. But this is a situation where we have an ability to solve our own uncertainty by going ahead and digging a little deeper. Now, we'll talk briefly that the locus of uncertainty can vary as well, meaning perhaps the provider, perhaps the patient, or perhaps both are uncertain. And we should keep in mind that just because we feel sure doesn't mean that our patient always does. Important not to be ignored. And pretty simple solution here, that good communication goes a long ways to transferring our certainty to our patients, and keeping that in mind. For this talk, we'll really be focusing on uncertainty among providers. So some very brief conclusions on that very first part of defining uncertainty. Remember, there are many types and sources of uncertainty, and that we should resolve uncertainty that is quote unquote fixable, particularly by asking good clinical questions and by explaining things well to our patients. Okay, so next, let's understand ways in which uncertainty affects us as healthcare providers. our second brief case. So now you're seeing a 55-year-old woman for allergic rhinitis. But at the end of the visit, she also mentions moderate right lower abdominal pain. The pain started a few days ago, is difficult to describe, and seems to come and go. No nausea or vomiting, maybe slightly constipated, mildly dizzy. She changed brands of eggs in the last couple of weeks and wonders if this might contribute. These, by the way, are cases of mine. And her physical exam, brief as it may be in the last minute of the visit, is unremarkable. So what would you do next? Agree that it might be the eggs and offer reassurance, advise that she begin Miralax, ask her to come back for a visit about this, order some basic labs, or go ahead and order the CAT scan. So here we are, most of us internists. When is it ever wrong to have another visit that gives you an opportunity for history and physical exam, right? So I think most of us would opt for C. But that said, there are probably times that we are tempted to do or have done several of the other options, perhaps with good reason at times. Let's take a look at why that might be. So how uncertainty affects us. It turns out that many of us didn't go into medicine to face a lot of uncertainty. That wasn't exactly what we have in mind. As conclusion of this case, I forgot. So she returns looking well. The abdominal pain is really improved, nearly resolved. But it's a little unsettling because she's not sure what it was, and neither are you. So ambiguity feels really uncomfortable, I think, to people in general, and sometimes particularly to those of us who are used to seeking solutions. And so we work to resolve it, and usually that is a good thing. But we can also be premature at times in our efforts to resolve uncertainty, and it can make us act in even irrational ways at times when we work to resolve uncertainty too soon. Epstein, noted at the bottom there, did a really interesting study, actually recording and observing interactions between patients and doctors with unexplained symptoms, and took a look to try to categorize how was it that the doctors ended up responding. And here were some of the things that commonly happened. It was noted that it seemed like the provider really rejected the patient's symptoms, was kind of unable to acknowledge them as real. Often premature reassurance can be given, leading to premature closure of a clinical case. And they may collude with the patient's explanation. Now, this can be a useful strategy sometimes when we're not worried and we want to provide reassurance, but can also lead to some pretty irrational thoughts. This would be the eggs. And we may really lose opportunities for good relationship with our patients or good opportunities to further explore important diagnoses if we close cases too soon. We may find ourselves stuck in cognitive biases when we look to close uncertainty before it really should be. Here are a couple of other responses. We as providers may also interpret patients' distress as a request for services. Patients come to us with their troubles. That doesn't always mean that they're asking us for tests. And we may order tests to reassure the patient, though I would say oftentimes we also may be making attempts to reassure ourselves when we are ordering tests. And let's take a little closer look at that. This was a nice systematic review and meta-analysis done just in the last few years by Dr. Rolfe, looking at what happened to patients after tests were ordered for conditions where there was a relatively low pre-test probability of a serious diagnosis. And they looked to see, did patients' level of anxiety lower? Did their symptoms resolve quicker after the test was obtained? And it turns out no. And in fact, sometimes paradoxically, we may see that test ordering elevates a patient's level of anxiety because they now are convinced that the doctor too is worried that there is something to be found. And I think we've all become increasingly sensitive to the idea that our tests themselves can carry particular harms, not just immediate harms of risks of procedures and imaging, but also incidentalomas or a cascade of further things that may happen as a result of positive or false positive tests. This was a description in JAMA Internal Medicine of a young woman who went on to have a left main coronary artery dissection after false positive cardiac imaging. Good to keep in mind. So now, knowing that perhaps we need to have some caution before throwing uncertainty to the wind, let's take a look at how it makes us feel to live with that uncertainty. This was published back in 2007 and took a look at correlation between work-related satisfaction and the amount of anxiety that physicians felt over uncertainty. So just to orient us here, so the gray line up top is community-based doctors. And then we have a hospital senior doctor, so like attendings. And then this is hospital doctors in training or residents. And what you can see here is as there is more anxiety among the providers, that is really heavily associated with worse work satisfaction. So those who feel really anxious about uncertainty in their work have a harder time feeling good about their work. I don't think this is too surprising, and interesting that it's particularly strong in those who still may be formulating their person and their competence as a provider. And I think as we think a little bit further about this, uncertainty can be a really positive and powerful tool in that it can be motivating and getting us to ask questions, to be curious, to work harder to try to find a solution. But it can also be tremendously stressful, particularly when we have great intolerance for uncertainty, to the degree that it can be paralyzing for some people if they're unable to move forward despite uncertainty that can't be resolved. And now that we know people have varying levels for their tolerance of uncertainty, I was going to show you a little bit about some validated scales that have been developed to measure it. So the first one is called the Intolerance of Uncertainty Scale, developed by Geller back in 1993. And here's just one example question from it. So, or statement, I should say. I don't like working on a problem unless there is a possibility of getting a clear-cut and ambiguous answer. So people will fall on quite a spectrum with regard to how they respond to this. And it was found that this scale seemed more reflective of people's person, their personality, and did not necessarily have traits or beliefs in the statements that were heavily movable. Garrity later did work to develop scales and specifically developed one related to physicians called the Physician Reaction to Uncertainty Scale. And here's one example statement from her work. I find the uncertainty involved in patient care disconcerting, right? So just like we saw in our graph a little ways back, perhaps those who find uncertainty most disconcerting also find then that their work satisfaction is less. And Garrity ended up dividing this scale into 4 domains, and the 4 domains included our anxiety due to uncertainty, concern about bad outcomes, reluctance to disclose uncertainty to patients, and reluctance to disclose mistakes to colleagues or other physicians. So now we can measure it to some degree. These scales are occasionally used. But it really raises some questions with regard to tolerance of certainty. Should we consider being tolerant of uncertainty adaptive or maladaptive? Is there a right level, and can it even be taught? So I alluded to this a little bit with regard to this being maladaptive or not. Kind of think of tolerance of uncertainty a bit like perhaps the trait of perfectionism, right? So a lot of there can be working hard that leads towards personal striving to do better, right? So efforts to resolve uncertainty, to be intolerant of uncertainty, can be highly productive as a physician. It can bring out the best in us. But there is probably a tipping point at which an absolute intolerance of uncertainty may become counterproductive. So I would claim there is probably a sweet spot there, though there may not be a right level for everybody. The right level, not surprisingly, there are some interesting studies looking at some traits that tend to go with greater tolerance. So people who are older when they graduate medical school, those who are early adopters in other realms, and those who gravitate to particular fields of medicine, not surprisingly psychiatry, highest among them, tend to be more tolerant of uncertainty. And I think some studies of the previous scales show us that those like the physician uncertainty scale may include some features or traits that are more teachable, whereas some of it may be a bit inherent to who we are as people. So again, digging a little bit deeper into, is there a right level? Here's a study by Carney back in 2007 that looked at mammography radiologists. And those that were interpreted by radiologists with greater discomfort with uncertainty had a higher likelihood of recall for further imaging programs. And this is difficult to say, is this a good thing or a bad thing? Which radiologist would I want to have? And there are clearly pros and cons on both sides. This was a very small study done by Gifford, very interesting, where neurologists were primed with cases suggestive of Parkinson's disease, which really, as we recall, is a clinical diagnosis. And they found that the neurologists, in deciding on their diagnosis and diagnostic workup, ordered far more imaging if they, as clinicians, felt less certain of the diagnosis. So again, their skill with regard to perhaps history, physical exam, experience, but then also, regardless of how certain they felt of the diagnosis, those who were less tolerant for any degree of uncertainty too went on to order imaging much more commonly. And this has been studied in other domains to try to get at what happens with medical decision making and utilization among physicians who are more or less tolerant of uncertainty. And this was more of a review article that looked at a number of studies and overall found that increased physician anxiety due to uncertainty, as well as that other domain, increased concern about disclosing uncertainty to patients, translated to higher charges for patients in general, probably due to more test ordering. There's been a little bit of mixed results in general with regard to trying to look at these scales and linking it to practice patterns, but as an interesting area to think about. And finally, just briefly to think a bit about medical education, an area near and dear to my own heart. Many of us have trained in situations where there has really been a culture of no stone left unturned, and really a reward for often doing more as our way of showing due diligence. And I would argue that in an era where a multitude of tests and procedures and next steps are available to us literally at the clicks of buttons, that the harder job may be to really train quality decision making so that we have ability to also show restraint when it's appropriate. So this may be a bit of the elephant in the room as well, perhaps in the back of people's minds as we talk about doctors ordering tests in the face of uncertainty. And that is questions regarding what is the role of defensive medicine, right? So this is medical care applied, presumably at least largely in part for the notion of malpractice concern. And just in the last few years, there has been some interesting work in this area. So let me just describe this first. This was a publication in Health Affairs back in 2013, where they looked at some basic chief complaints: headache, chest pain, back pain, I believe was the other one, and looked at practices across several states that had very different climates with regard to sort of the threshold for malpractice suits. So sort of looking at objective measures of the risk of being sued in different areas. And what they found was that, well, I'll show you what they found. So they found that physicians who reported a high level of malpractice concern were most likely to engage in practices that would be considered defensive, if that makes sense. But they did not see a consistent relationship when state-level indicators of actual malpractice risk were replaced the self-rated concern. So as it turns out, the climate of tort reform in the state had much less bearing on whether providers were ordering in a defensive way, as did the individual's level of concern over being sued. It's another sort of similar study that I'll run through with that. This was even more recently published in New England Journal just back in 2014. This study was done in emergency departments, largely because of the high acuity and fairly high risk, both in terms of clinical outcomes but also risk of lawsuit. And they looked at some states that had malpractice laws and then really had significant reform in the sense that the bar was raised significantly to gross negligence needing to be met before there was an opportunity for legal risk. And practice didn't change after the law changed. And there may be a lot of reasons for that. Practice patterns, for example, are already established. But I think it emphasizes to some degree, again, that physicians, to some degree, may overstate that their ordering is due to a fear of malpractice, when in fact sometimes it may be their own level of concern. So some conclusions in this domain in terms of how uncertainty affects us. I would say uncertainty is stressful. And we have varying levels of our tolerance for it. I think it's interesting that premature attempts to resolve uncertainty can actually lead to irrational decisions. And I would argue to some degree that defensive medicine may result as much from uncertainty or intolerance of uncertainty as it does from the actual level of legal risk. Okay, into the last stretch. So we're going to discuss now some strategies for managing uncertainty now that we're aware it exists and we may need to live with it. Are there some constructive ways that we can look at lowering it, and how might we move forward even when we can't quite resolve it? So Holmes described back in 2011 that practice of the medical presentation, one of its greatest purposes, is a way of adding clarity to complex and uncertain situations. So I think this is helpful to think about, as sometimes presentations are considered just an exercise, that actually quality case presenting, quality note writing is a way that we organize our thoughts and that we as clinicians may reduce some of our uncertainty as we work through those cases. Decision support and clinical algorithms can be useful ways to help us move forward and add clarity to cases. These are often limited by imperfect data and evidence, so applying them pragmatically in the clinical setting can often fall short. And finally, I would say we should be mindful to really adhere to the best evidence when it is available, looking for evidence-based guidelines to help us out. That said, these guidelines really do need to be evidence-based as opposed to expert-based. And we do need to be sure that they provide us general guidance, but not to be followed blindly, because they generally don't apply to all of our patients and can in fact lead to unnecessary care as well if followed without thought. Another area, could be a talk in itself, is to discuss physician numeracy. This is kind of understanding of concepts like pre-test probability and how that may translate to a post-test probability, and really good understanding of some of these numerical concepts that go hand in hand with evidence-based medicine makes us less susceptible to cognitive biases, and focusing in not only for our trainees but for ourselves to understanding these concepts well so that we don't misstep with things like false positive tests is a really important area to think about as a tool to reducing uncertainty. A last strategy I would mention would be remembering the beautiful use of time as its own diagnostic tool. Eisenhower said, "What is important is seldom urgent, and what is urgent is seldom important." This is not necessarily always true in medicine. We do see plenty of diagnoses up in here and don't want to forget those. But there are many things that can wait, and having a bit of patience, some of these things can sort themselves out. Also important to remember that these two boxes can be pretty important to patients. So sometimes things that aren't urgent are very important to our patients, and not to forget to pay adequate attention to them. Some of you may have been around when Kurt Kroenke came out as part of our Value in Healthcare series as a speaker a couple years back. He has done a lot of interesting work with regard to the epidemiology of clinical symptoms. This is from his paper published a couple of years ago that was a systematic review of this epidemiology. A lot of people take a stab at what proportion of physical symptoms are medically unexplained. 10, 25, 33, 50, or 75. I'll let you make a commitment in your mind. So it turns out about a third of symptoms go unexplained. Right? So uncertainty is all around us all the time. And about a quarter of physical symptoms will become chronic. So it's not that it's just unexplained and it goes away and oh well. We often, and I think many of us feel this in our practice, there are a lot of symptoms that we don't have a perfect explanation for, and they may hang around for a long time. So Dr. Kroenke also helped us out with some thoughts for how we might manage in these situations. So we're now in the realm of uncertainty that can't exactly be resolved, and what can we do? So communication, we all might guess, is absolutely key. It can be helpful for the provider and the patient to agree for a name so they have something to call this elephant hanging out there, and that may just be the name of the symptom itself, because we don't want to apply an inaccurate diagnosis. It may be headache, or it may be your dizziness, but it should have a name. We know that we need to follow these people closely, perhaps frequently, at least for a while, and perhaps acknowledge to ourselves, but also educate our patients that we may be prepared for ambiguity to persist for a long time. He has a couple of questions that he proposed we may use more commonly with patients. One, because they may give us really helpful insights that occasionally can actually find an explanation and reduce that uncertainty, but also really are strategies to make our patients well heard. So, was there anything else you were worried about? Is a question that can be tremendously useful and can help us avoid the pitfall of these hand-waving explanations that we sometimes find ourselves in, where it turns out we're speaking to issues that weren't even the central concern for the patient themselves. And finally, was there anything else you thought might be helpful? This kind of gets it out on the table. There may be requests that you can help educate. That's not a useful next step. You could end up with things like, I think this is from the eggs, like we saw in our case before. But you might get some really useful insights into the patient for what they think may be useful. And a couple of reminders, at least from Cronke's perspective, of things to potentially avoid when we find ourselves in this situation. So this I find a difficult word to pronounce. If anybody wants to take a stab, feel free. But the idea here is that just because a symptom cannot be explained by a specific physical finding does not mean it is a psychiatric diagnosis. Okay, so you can have an unexplained symptom and just leave it at that. It doesn't need to be psychiatric. And to some degree, so right, reassurance, critically important, but patients don't necessarily like to hear the words out of your mouth, everything is normal. It's okay to acknowledge that it's not good and maybe not even normal to hurt in an area, to feel dizzy. So you can talk about tests being normal and such, but telling patients everything is normal is not necessarily a very useful strategy. Okay. So we're really lucky to practice in an era of a strong evidence base. There's a lot of good information available to us these days, and I think also a culture in which we are accustomed to trying to practice in a way that is evidence-based. That said, I think many of us know there are limitations, and also it can be difficult to apply the evidence to the singular patient in front of us, right? So even when we have good evidence, that is usually based on a population of patients, and that may or may not apply exactly to this individual. And when we lack the space and patience and tolerance to acknowledge that, we can fall into something that Griffith refers to as a myth of certainty. And one strategy that Griffith suggests is to negotiate provisional decisions with our patients. So this is a situation where we may acknowledge this is what we think based on your current situation, based on the medical evidence that we have, but being open-minded and tolerant to the idea that this may change over time as circumstances change. So a lot that could be said about that, but I'll move on to a second related concept that Hewson describes of strategic medical management. These were 9 strategies or features that he described as ways that you and your patient may use to be able to make decisions and move forward in a rational way, acknowledging that some uncertainty still exists. So I just picked out a few that I find most useful in my day-to-day practice. Many of these we do intuitively with the experience that we have had, but as a reminder, one strategy we may do is alleviating fears and concerns, calling it out. I know you are worried about X, but I don't think it's that, right? So the patient with chest pain, right? You may not have the perfect explanation, but I don't think this is a heart attack because. Describing the prognosis can be helpful. Sometimes we may not know. This doesn't always apply, but there are situations where we can prepare our patients for what they might expect over the next hours, days, weeks. So they have some sort of time frame over which to think about when should I be calling back. We can make provisional diagnoses while keeping alternatives in mind. So I think it's X. We're going to treat you for that. But I'm going to keep thinking in the back of my mind, right? And also planning for contingencies. So this can be the not so useful emergency department room after visit summary with, if you get X, Y, Z, blah, 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 come back, right? So we have to be careful in how we apply this, but thoughtful comments to educate our patients for which things really would worry us. When do I really do need to see you back can be super useful. Okay, circling back briefly to medical education. So now we're talking about how do we teach knowing that we can't solve all uncertainty. Point one, I'd take us back to the very beginning of remembering there is a lot of uncertainty that we can solve, right? So helping our trainees perfect their skills in history taking, really working through high quality clinical decision making, asking good clinical questions, looking things up, asking for advice. These are all critical ways that we need to think about teaching our trainees to resolve uncertainty. But also, I think we have seen increasing attention to the ideas of high-value care, and we as physicians have a responsibility to train good stewards of our resources. And these concepts have been taken up enough into the popular culture of medicine and medical training that there are questions now incorporated into the American Board of Internal Medicine certifying exam that look at the ability to also know when to do or not do things. So here's a couple brief examples of questions from the ABIM. So, 62-year-old woman comes to your office as a new patient for a periodic health evaluation. She has smoked 1 pack of cigarettes daily for over 30 years. She has not had cough, shortness of breath, or wheezing. She has hypertension, for which she takes hydrochlorothiazide. She gets her spirometry and it shows an FEV1, 80% of predicted, FVC, 90% predicted, and a ratio of 75%. In addition to smoking cessation, which of the following should you recommend? No additional therapy, ipratropium, tiotropium, albuterol, or fluticasone. So I think most of us are in tune here, right? Doesn't really meet the criteria for an obstructive ratio, plus she has no symptoms. And though we're often tempted to do things, this patient doesn't actually need anything more. The correct answer should be no additional therapy. Here's a second question. 38-year-old woman has had vague abdominal bloating and back pain for 2 to 3 months. She has not had dyspareunia or menorrhagia. Menses are occasionally irregular. Her last menstrual period was 2 weeks ago. The patient takes no medications. She has 1 child. The pelvic exam reveals a non-tender right adnexal mass. Physical examination is otherwise normal. The Pap test is normal, and a pelvic ultrasound shows an irregular 10-centimeter right adnexal cystic mass with thick walls, septa, and areas of nodularity. Which of the following is the most appropriate next step? And I think, again, somehow these questions, at least reading them now, seem easier than some we get on our exam. But right, so this is a concerning mass. The answer for this is a surgical consultation. And I show you these 2 questions because they were actually 2 examples that were given from a study just done in the last couple of years. And what this figure is showing is these are practice programs, many of them across the country. And based on billing data, there are programs that are considered higher and lower intensity with regard to medical spending. So programs over here spend less. Programs over here tend to spend a lot more. And what they found was basically in responding to these test questions, those who trained at programs with lower intensity spending had a higher ability to respond correctly to questions that required some degree of restraint with regard to not doing things. And this scale is actually keeps a pretty fair scale, so this line is kind of subtle, but this is actually a 27% relative risk reduction. It looks like about an 18% actual reduction with regard to the score. And this was Sirovich's conclusion from the study, regardless of overall medical knowledge. So the programs had scored similarly with regard to questions in general. Internists trained at programs in hospital referral regions with lower intensity medical practice are more likely to recognize when conservative management is appropriate. And these internists remain capable of choosing an aggressive approach when indicated. So it wasn't that as an unintended consequence they were under-ordering in other situations. They scored equally as well as things where really next steps were medically indicated. And there are other interesting studies showing that much of the practice patterns that are established by where we train then persist throughout our careers. Korenstein wrote a commentary in JAMA a couple years back using this terminology, which I kind of like, called minimalism, where she said, minimalism is not about cost, nor is it overtly about the avoidance of harm. It's just a bit of a shifting of the default setting away from interventions and toward conservative approaches. For me, this is a concept that sits hand in hand with some degree of tolerance for uncertainty and perhaps shifting the tipping point a bit. So some conclusions from this final section. I would say adhere to evidence-based medicine, but recognize the complexities of applying to the individual at the bedside. Recognize the importance of physician numeracy and time as a diagnostic tool. Utilize communication strategies that reduce the anxiety of uncertainty for patients as well as for us. And recognize that minimalism may be an important aspect of the informal or hidden curriculum of medical education. This is a quote that I really like by Dr. Campbell from a piece written in JAMA a couple of years ago. Uncertainty permeates the practice of medicine, but medical training urges students to think in terms of verified facts and certain conclusions. To work with a team, develop broad and encompassing differentials, eschew cognitive biases, recognize our own limitations, and I believe fundamentally empathize with our patients, physicians must learn to tolerate uncertainty and work effectively within its bounds. So here were the objectives that we walked through. And I'm going to stop there to see what comments or questions any of you may have for me. Thanks. Happy to take any thoughts. Yeah.
I wondered if they've done any. I think your point about codifying your impression in a note is important.
Yeah.
And, I wondered if they've done any studies looking at the electronic medical record versus conventional soap notes.
That's a super fascinating question. So it was that the concept of using our notes as a way to really process our thinking and reach our conclusions. If there's been any studies looking at physicians' ability to do that when we used to write our notes versus doing them in the electronic medical record. I don't think so. I'm not aware of any studies that have really dove into that. I think we as providers and perhaps also as teachers have become pretty acutely aware of various challenges with note writing in the electronic medical record. The ease of carrying past thoughts forward can be a barrier for us doing that iterative rethinking of new information and data. So I do think that's pretty interesting. I think it's hard to know what to do with notes now, and to some degree we may be better served by shorter notes that actually pay more attention to an outlining of a thought process as opposed to kind of a laundry list of problems. But no, it's a great thought. Yeah.
Great talk. In the work that you did looking in the literature, and this following up a little bit, a lot of the studies focused on clinicians themselves and outcomes and that kind of thing, but were there studies that actually looked at how patients dealt with physician uncertainty and what physicians did with different patient input?
Yeah, great. So the question is, so I focused on some studies that looked at how did physicians feel, right? And what were outcomes related to physicians and how uncertainty made them feel. And are there studies in the literature that looked at it from the patient perspective? So how do patients feel about their physicians feeling uncertain, and do they have preferences with regard to whether that uncertainty is conveyed or not? Yeah, there are a few really interesting studies, and a little bit, on my take, a little bit nuanced to interpret, but the conclusions that I took were, if you just look at face value, patients were less satisfied when physicians seemed to show a great degree of uncertainty, which in ways doesn't seem surprising, and in ways kind of made me nervous as I'm talking about this. But when they dug into that a little bit deeper, they found that the worst combination was physicians who showed uncertainty but then were directive. And in fact, the best was actually being engaged in some degree of shared decision making. And so it seemed that it was fine to acknowledge, and perhaps even a positive, to acknowledge that there is ambiguity here. And now I'm gonna engage you to help us make a decision to move forward. So yeah, there were a few interesting studies with that. Great. Yeah.
I'll ask another follow-up. Another movement is, patients being able to access electronically their charts, including the open notes movement, which is real powerful.
Yeah.
Have you seen any studies that deal with it, with the ability for patients to kind of engage with their providers, the information that on their own health care, and how this affects their working with uncertain diagnoses?
Right, so a question is, now that patients have increasing access to their own electronic health record and through projects like Open Notes, whether the ability to see information about their own uncertain diagnoses is either helpful or harmful in engaging them in that conversation. I have not seen that studied. I'm not super familiar with the actual literature, probably limited as it is, regarding Open Notes. My other primary hat I wear outside of medical educators is a primary care physician. Our clinic, which is a teaching clinic, went to Open Notes probably about a year ago. I have to say, people had said, and yet I was still surprised that you hear very little. It is exceedingly rare that patients come either through my chart or in person with questions about things in their record. That said, they seem to be looking at things and engaging with it, but it doesn't seem to have raised a lot of, wait a second, doesn't look like you know what you're doing. So that's been interesting to me personally. Yeah. Great. Yeah.
At the Mayo Clinic, that's where people go for the ultimate diagnosis. So you obviously order a lot more tests than anyone else would, I would think. How has that affected you and your practice?
Yeah, super interesting. So I trained at the Mayo Clinic, right, which certainly at least has a reputation as being the place that people go to get the answer. It's interesting. So I have very fond thoughts about my training there. I feel like I got good clinical training. And it's a little bit mixed. So it turns out Mayo is a little bit of this bubble. Nonetheless, it does sit in rural Minnesota. And culturally, it is interesting in the Midwest. There is a strong tolerance for uncertainty in general, I find, culturally. And even though many of the people who practice at Mayo come from afar, there is still something to that there. And a lot of patients there are seen as a referral population, but at least about half the population is treating local Iowa, Wisconsin, Minnesota. So there's that piece culturally, which is interesting. And I would say there a lot of the finding the diagnosis has to do with coordination of care and also probably clinical expertise. So a lot of test ordering is often done quickly and upfront. So if there are things to be done, it's sort of done collectively. But the overall spending at Mayo per patient is actually quite low on the spectrum, particularly compared to other tertiary referral centers. So I actually felt like I learned from very experienced clinicians who ordered a lot when appropriate, but there were a lot of patients that I saw there for whom there was not always an answer and an ability for, I think, them to say at Mayo, we've done what we can do here, and also educating patients when things were unsolvable. Yeah. So interesting question. I hadn't thought about that. Yeah.
Where and how do you deal with the worried well in the figures of 33% who have unknown reasons?
Right. So how do we deal with the worried well, and particularly knowing that a third of complaints of symptoms will go unexplained? Oh, how many of them are the worried well? I see. Yeah, I don't know the numbers, but I would say probably quite a few. Yeah, I mean, I would say the difference is, and I'd be interested to hear your thoughts too. I think there are some of the worried well that have frequent and often transient symptoms that worry them. Cronke's epidemiology dealt to a large degree, at least with a quarter of them, that were symptoms that came and tended to persist. But yeah, for those that are unexplained symptoms that are short-lived, particularly, those may often be people who are well but concerned, and are the perfect example of giving it some time and some communication strategies before delving into a big workup. If you had other places you were going with that or thoughts, it'd be interesting to hear. Yeah.
Mayo being in the least expensive expenditures for Medicare patients.
Yeah.
Gawande's study with the two Texas places, one was 15,000 and the other was about 7, and I think that's where your study comes. I mean, where
Thank you for the reference
Mayo
on that. Yeah. Great. Great. Thanks. Feel free. Thank you.